Good morning, Anna.
Morning. How are you? Everyone well?
Good morning.
Yes,
Yes, good. Morning.
good morning.
Hi.
Hi, Helen.
Hey, Helen.
Hey, happy Monday, everyone.
Happy Monday. Just for context, Helen and I are working together today, and we have quite a day with a lot of logistics to organise because I'm not sure everything's going to fit in one car. Everything and everyone. Anyway, we'll sort that out after this. Um, so today's topic, it's not actually a chapter in Edinger. So the interplay between cardiac and renal disease, but I chucked it in because I think it's potentially examinable. And we just see there's a few kind of review articles linking these two diseases really nicely and the kind of elements of it. I thought about putting this topic at the end of the cardiac kind of unit that we're doing, but actually I think it's a really nice intro on kind of the pathophysiology of heart failure, which we've wedged in to the physiology of like heart physiology, which is in a fortnight's time. And I just thought that's too much to go through altogether. So we're going to talk about the interplay between cardiac and renal disease, but we're going to be talking about in that what changes are there with congestive heart failure and chronic renal or acute renal injury that will impact the other organs. So tell me, why are the kidneys so sensitive to cardiac function?
Because they take 25% of the cardiac output.
Yeah, absolutely. So decreases in perfusion are absolutely going to impact renal function. What else does happen
RAAS,
with congestive heart failure?
RAAS activation,
Yes, excellent. Let's like break that down a little bit. What's RAS?
renin-angiotensin-aldosterone system.
System? Good, excellent. Let's break that down even further. Renin, what does it do?
Um, it just tells it converts angiofibrinogen to angiotensin. It's a signaling molecule.
Angiotensinogen, yeah.
That tensinogen, yeah.
Yeah, yep. Perfect. Which does,
What does angiotensin do?
yeah,
Um, Triggers hemodynamic changes,
yeah, perfect.
causes fibrosis.
Yes. So hemodynamic changes in a hypertensive direction or a hypotensive direction?
Hypo.
Yeah,
Hyper.
hyper.
Angiotensin, yeah.
Constriction.
It will cause contraction of those vascular smooth muscles and that increases blood pressure.
Oh, yeah, of course. It's the inhibitors that decrease blood pressure, of course.
Exactly. So this is where, and this is, I've like just thrown a bunch of hard questions at you, Matt, as I'm seeing a baby flying past your window. um, and I like you obviously you answered those really well, and I apologize for just putting you on the spot at 8 a.m. on a Monday morning.
Right.
But I think it's really this is an area where there's a lot of almost double negatives because we use a lot of inhibitors of these RAS parts, and it's really important that we understand what the actual enzymes or chemicals are doing in the body, and then why they've become a target for therapeutic intervention.
And on that point, then, if angiotensin, I would then also assume it triggers aldosterone production.
Yeah,
No,
good,
as
excellent.
like the next part of the
Yeah.
system, which leads to
So
fluid production, sodium retention, and therefore fluid retention.
yeah, yes, perfect. Now I've just realized I forgot to close the door. So can you tell me what you've just told me what aldosterone does? But tell me how that affects blood volume while I close the window.
Or increase blood volume.
Good. So that whole system is designed to increase blood pressure by increasing vascular tone, but also increasing volume, circulating volume. So we get fluid retention as well as increased vascular pressure or hypertension, or normal blood pressure if it's in a functional setting. Excellent. So I don't want to go too much into how congestive heart failure affects RAAS, but there's one other kind of part of how heart failure develops, or something that's kind of activated when heart failure starts, which will impact the renal function as well. That's separate from RAAS. Early on, one of the very early kind of maladaptive responses to, well, kind of adaptive responses to a heart that's just starting to fail.
Do you mean like increase sympathetic tone to increase your contractility and heart rate, but that will cause peripheral vasoconstriction, so might drop your renal blood flow?
Yeah, exactly. It might drop your renal blood flow and also cause some hypertension. So we've got RAAS and sympathetic activation, both contributing to increased afterload, which is kind of maladaptive for the heart, but beneficial for the kidneys. So we start to see that sort of interplay. Whilst I don't want to talk too much about RAAS, when we've got increased circulating volume, we've got really good systems within the arterial system to adjust to that and make sure that blood pressure is kept within a good range. What happens in the other side, in the venous system, when we've got increased volume and circulation?
Increased hydrostatic pressure.
Good. Excellent. Yeah. So the veins are quite good at just accommodating changes in fluid volume to a certain point. And then we start to get increases in hydrostatic pressure. And how will that impact the heart?
Well, increases
Preload.
preload, yeah.
Yes, excellent. Yeah, excellent. So then venous congestion within the lungs is a big deal, right? That's what leads to pulmonary edema. And increased pressure in the kidneys is actually a contributing factor to edema and decreased renal function. So increased venous pressure will impair renal function as well.
And does that damage the glomerulus as well? Like, is that part of the proteinuria glomerular? I mean, I know there's obviously like immune complexes and other things, but is it part of what drives like that preload, which is like causing damage to the glomerulus and pushing protein through?
That's such a good question, actually. So I think yes.
Because I think sympathetic tone is like a problem with that
much
as
higher,
well.
much bigger. Yeah. So
Yeah.
where the glomerulus, so the glomerular arteriole comes in, it wiggles around in the glomerulus, comes out, and then it wraps around the whole nephron. So it goes right down into the medulla, right up back into the cortex, and then out through the renal vein. So where you've got venous congestion, it has to back up right through that medulla. So you get interstitial edema in that kidney, which is then going to take up functional space and squash nephrons and decrease flow through those nephrons. So we get nephron loss secondary to interstitial edema before it would back up into the glomerulus. But in theory, if it was bad enough, it could.
Thanks.
Excellent. Okay, so we've sort of talked about how cardiac disease could potentially contribute to renal disease. There's one more big thing that we do, which is going to mess with kidneys big time in our heart dogs.
Diuretics.
Yeah, exactly. Yeah. And obviously we have to use them in dogs with congestive heart failure. But we are walking a line between compromising renal function in a system which is already under a lot of pressure and prioritizing the heart health. So we're not going to talk too much about treatment of congestive heart failure at this stage, but let's just talk about where and how furosemide works in the kidney.
Loop diuretic, loop of Henle. I think it prevents, this is where I always get confused, it stops the sodium potassium chloride pump
Yep.
and stops the active reabsorption of sodium, or the other way around. That's where my brain goes. Whoop.
Excellent. So you're exactly right with the NAK ATPase pump in that it inhibits that, which means that sodium's not moved out of the interstitial cells or the tubule cells, which means that sodium just keeps moving through the tubule and takes water with it. So sodium is like, oh gosh, we're going too deep. But sodium goes tubule in and then into the cells that line that tubule. And it's really reliant on that NAK ATPase pump, which is active, to pump the sodium up its concentration gradient out of those cells so that then the sodium can flow passively into those cells. So it keeps the sodium levels low inside those cells to keep that movement of sodium going into the kidneys. So when you inhibit that pump, the sodium just stays in the tubule. It's because there's no concentration gradient between the cells and the tubule. Make sense? And then water follows sodium. So you can't really get sodium excretion without water. Excellent. So what impact will that have on renal perfusion? How does that link?
Will decrease blood volume.
Yeah, good. Excellent. Which then decreases
perfusion.
Perfusion, exactly. Yeah. And our whole objective when we use furosemide is to decrease blood volume, isn't it? We have to do it because there's too much in that venous system. It's backed up and causing congestion, and we have to get rid of that preload to keep the edema out of the lungs. Now, key sort of concept, kind of jumping to the end of the topic, but a key concept in management of heart failure is what dose of furosemide do you go with? And I say this a lot, and you've probably heard me say it before, but it takes a lot more furosemide to get rid of edema than it does to keep it gone. So when you've got a system that's really backed up, really full, you need a lot of furosemide to get rid of it. And that's why we give boluses or infusions to our congestive heart failure patients. But often they don't need anywhere near those doses to maintain that edema. And when we're trying to manage the impact, particularly when there's renal compromise, we have to walk that line with using the lowest possible dose of furosemide we can get away with that's not impacting, it's definitely going to impact renal function, but is impacting it as minimally as possible. When they're in congestive heart failure, don't be conservative. Get them out of congestive heart failure and then back off. So we talked about how cardiac disease impacts renal disease. Is there any other way that renal disease might impact cardiac disease? The other way around?
Yes.
Yes.
Yeah. So uremic toxins can contribute to endothelial dysfunction and cardiac remodeling.
Great. Excellent. Yeah. And not just the toxins, but actually aldosterone. Yeah. Is one of the contributors to cardiac remodeling and one of the theories behind spironolactone being therapeutic in prevention of remodeling.
So it's like spironolactone's like lesser known use as a aldosterone. Well, I mean, it's an aldosterone antagonist, but it's not just a diuretic.
Exactly. So it actually prevents remodeling, which is where the main therapeutic benefit in congestive heart failure, rather than as a diuretic. It's a hopeless diuretic. Potassium sparing, which is nice. Excellent.
And then I know it's probably too deep for today, but mitochondrial dysfunction is like the new cardiac renal axis consideration.
Yeah. I am really interested in that, and I do have oxidative damage on my list of ways that renal disease impacts heart disease. Can you expand on mitochondrial dysfunction?
Not really. Not really. I think, well, I mean, yeah, the most most processes in the kidneys end up being like high oxidative stress. And I think the myocardia is like another very sensitive tissue for oxidative stress. Yeah, but yeah, and I guess the details of how the mitochondria, and I think it's just that they're both mitochondrial rich, and maybe something to do with the mitochondrial receptor.
Don't know.
I don't know.
Don't know about the receptor. I think the main thing with
Maybe that's serotonin receptors, that they both got a lot of
Oh.
serotonin. That's another kind of link, I think.
Yeah, right. So what is the mitochondria's job in a cell?
Energy production.
Energy.
Good. Excellent. So a heart cell that's like working its ass off, it's never worked harder in its life, it can't work any harder than it's already working. If you then decrease mitochondrial function with systemic inflammation, what's going to happen to the energy production in that cell, or the capacity of that cell to work as hard as it possibly needs to?
Geez, obviously.
Yeah, exactly. So systemic inflammation decreases the mitochondrial function, which contributes to oxidative stress, which essentially means that that cell is working under anaerobic conditions, which is not sustainable long term. And we need these myocardial cells to just get as much energy as possible to be able to function. So systemic inflammation impacts remodeling due to the damage to the myocardial cells. That was pretty deep, Matt. Any other ways that renal disease will cause or exacerbate cardiac disease?
It's going to lead to chronic sodium water retention. Did we already cover that? Did we say because of the RAAS activation? Because then we're going to get increasing circulating volumes. It's going to put you at worse risk of going into congestive heart failure, and it's going to cause hypertension, which is going to increase your afterload and worsen cardiac function potentially.
Excellent. So we're going to increase preload and afterload. So we didn't talk specifically about renal disease causing that. We talked about cardiac disease causing that and impacting renal disease, but it works the other way as well. So RAAS activation is occurring in both primary disease processes, whichever one's happening fastest and first. So hypertension is a really big one, and one of the reasons I put this in as a topic on its own is because there is a consensus statement on it and how they manage the different forms, drawing from like human classifications that they use. And their strong recommendations is to manage hypertension early and aggressively in patients that have concurrent cardiac and renal disease, even if they're not in failure, just if they've got a murmur and compromised kidneys. Hypertension has to be a goal of therapy. Management of hypertension has to be a primary goal. There's one more, which is a little bit, it didn't pop into my head. I had to look it up. One of the complications of chronic renal disease, which might impair heart function.
Potassium imbalance?
Oh, that didn't pop into my head at all. Yeah, absolutely could. When you've got, for example, oliguria or anuria, potassium increases. What does that do to heart rate?
Decreases it.
It decreases it. It makes it less excitable.
Good. Yeah. And can we decrease heart rate in these dogs that are on the edge of going into failure? No, it's going to make it worse. Good. So that's quite a problem with oliguric and anuric renal failure. It's not necessarily a problem with like chronic kidney disease. What usually happens with chronic kidney disease to the potassium balance?
Potassium goes down.
Yeah, so they're usually quite low, actually, aren't they? Now, potassium's, we're going to talk about cardiac physiology next week. So we're going to talk about how the ions move in and out of the cells. But potassium is so important for repolarization. And repolarization is that phase where all those heart muscles are relaxing. So when a heart's failing, you want contraction to happen as fast as possible, and you want relaxation to happen as fast as possible. You don't want there to be any delay in that repolarization process. So any changes in potassium level will impact heart function. But because it's such a low number, we don't have really good data on like at what level do we need to maintain the potassium at?
Mm.
And how does this potassium impact the heart in this way kind of thing? But logically, potassium level is absolutely going to impact cardiac function, particularly that relaxation phase, which is so important to let the heart fill as passively as possible with as little energy from the heart as possible. There's one more. There's probably more than one more, but one more on my list.
Decreased erythropoietin if you've got really advanced CKD and then you're anemic and your heart has to work harder.
Yes, good. Yeah. So two main effects if you've got anemia, which is really common in chronic kidney disease, is that all of your cells aren't getting enough oxygen. So when you're anemic, your heart rate goes up. So it puts more pressure on your heart to deliver oxygen around the body. And then your actual myocardial cells are oxygen starved. So again, they're working sometimes in an anaerobic state, which they really don't have capacity to work in. So a few different considerations and reasons why we might be a little bit more proactive in intervening with particularly hypertension and anemia in patients that have concurrent cardiac disease. Okay. So the classification system, if I just read that out, have you guys seen that paper? Or is anyone in that sort of stage of study that they're researching? No. So this consensus statement just divides up the interplay into 5 categories, and it's very human in that some of the heart diseases that humans get, we don't get, like myocardial infarctions and decreased systolic function as a result of like dead bits of heart tissue, basically. So the categories that are important to us are really where chronic degenerative mitral valve disease and congestive heart failure contribute to renal dysfunction, which is type 2. And type 4, where we've got primary renal disease contributing to systemic hypertension remodeling and exacerbating a potentially degenerative heart change. So primary heart disease, predominantly mitral valve, and primary renal disease. There's a type 5 also, which is essentially systemic disorders which are associated with endothelial dysfunction, so systemic inflammatory disorders or systemic hypertension, which will then impact both. So not the kind of primary heart or primary renal, but systemic disorders which will then impact both functions. What about, so we've talked about how furosemide impacts the kidneys. Let's talk about how ACE inhibitors impact the kidneys. We're going to do the double negative thing, Jeff.
RAAS blockade?
Yeah, exactly. And how does that actually impact the kidney?
It reduces intrarenal pressure.
Good. So it opens up that afferent. I'm sure that's the one that goes through the glomerulus.
Efferent arterial dilation.
Good. Yeah. So when we've got, I'm just making sure that I'm not getting the double negative wrong here. Oh my gosh, how does it work?
So angiotensin 2 causes efferent arterial vasoconstriction.
Yeah.
So that increases pressure and helps to maintain GFR when your RAAS is activated. So if you block that, you get efferent dilation, which then reduces the pressure. So it's protective on your glomerulus, but you could risk dropping your GFR by inhibiting the vasoconstriction.
So many double negatives.
I know.
because the other double negative is that like once nephrons are dead, the remaining nephrons become hyper functioning, right? And then that in a compensatory mechanism, and so that is also what then leads to progression if you don't support them for longer, right?
Yeah, absolutely. So we're trying to save every single nephron we can when there's chronic kidney disease or risk of development of chronic kidney disease. And ACE inhibitors, like potentially very beneficial in terms of decreasing that pressure in the glomerulus. As Helen said, they run the risk of actually decreasing GFR completely. Yeah, exactly. So if you're not kind of holding that blood in that glomerulus, then that nephron perfusion, and as we said, that blood vessel, once it comes out of the glomerulus, wraps around the entire nephron. So if we kind of lose pressure in that blood vessel and circulation in that blood vessel and get stasis in there, then we're going to lose the whole nephron, because that's the blood supply for the whole nephron. Same thing if we've got hypertension damaging that lining of the glomerulus, of that glomerular blood vessel, and we get a clot forming or damage to that blood vessel, then the whole nephron is lost as well. So hypertension in the glomerulus is dangerous, but hypotension as well. So we deal often with patients that require boluses of furosemide to decrease their preload, remove pulmonary edema, clear pulmonary edema, and get them out of life-threatening danger. In theory, ACE inhibitors should be beneficial in terms of turning off that sodium fluid retention and managing afterload as well. Why do we often not start them at the same time as furosemide in that setting?
So you can understand the renal function
Yeah.
better and give, and there's a delay in the like there's a delay in RAAS activation after you drop the like we use the furosemide.
Yes. So a few points there. So first point, what would you say first?
That you can see what the baseline renal function is once you've corrected the congestion.
Yeah. So what we're doing, why we need to monitor renal function is because by decreasing blood volume, we're actually decreasing renal perfusion, aren't we?
Yeah.
So often what we aim for is to increase urea, because that's an indication we're giving enough furosemide, but not increase creatinine above a reference range, because we know that creatinine going up suddenly will cause nausea and make the animal feel unwell and less likely to be able to hydrate themselves and compensate. And we need them to be drinking when they're on furosemide and managing their own hydration status, because we don't want to put them off fluids too.
I saw in humans that they're like if starting an ACE inhibitor and they're like their follow-up week, like the 1 week follow-up renal parameters, that they said up to 30% creatinine jump is acceptable.
It's quite big, isn't it?
Mm.
Yeah.
Yeah. But interesting, I wasn't aware that like that the within urine. I mean, I ignore BUN more than creatinine, but I wasn't sure. I wasn't aware that like a fast jumping creatinine triggers uremic symptoms faster than that they kind of have different levels of uremic possibility, I guess, potential.
It's more actually, I think it's not actually the creatinine that makes them feel sick. It's that the creatinine is a more accurate marker of GFR, and you can assume that the other uremic toxins are going up as well. Yeah, okay. So it's not sort of saying that creatinine is the troublemaker.
More potent, like, yeah, gotcha. Okay.
No, because there's so many, as you know, uremic toxins that contribute to that nausea and stuff.
Yeah.
So balancing that diuresis with renal injury essentially is really important. If we were to start an ACE inhibitor at the same time as we were dropping renal perfusion through the floor, because we have to save this animal's life, we know that then that's when the effect of the ACE inhibitor opening up that efferent arteriole is going to pose a high risk to decreasing perfusion for that nephron.
The double hit, right?
Yeah, because ACE inhibitors don't really, as you said, Matt, they take a while to work. They're not going to have a really acute effect on volume retention and stuff as much as furosemide is. So I would never, and most people aren't starting ACE inhibitors with dogs with heart disease now anyway, but I would never start furosemide in a dog with pulmonary edema or a cat with pulmonary edema at the same time as an ACE inhibitor, because of that high risk. So typically I'll do the furosemide, get them out of failure, get them home and stable on the furosemide, And then if I felt like an ACE inhibitor was indicated, I'd start it a couple of weeks after. Just to make sure.
Will we be talking about when an ACE inhibitor is indicated for cardiac disease at another tutorial?
Yeah, we're going to do a whole one on treatment of congestive
Okay.
heart failure. Yeah,
Oh,
or treatment of heart disease, I should say.
Yeah.
Is that right, Helen? We've got a whole one on that, don't we?
Mm.
Yeah, we've got it. So the next one's all like physiology and pathophysiology. And then the one after that, I think, is treatment. And then we'll talk about weird congenital and stuff like that.
Okay.
Where are we up to? So has anybody seen any evidence or papers or anything that shows how renal disease or heart disease impacts each other, or is it all kind of theoretical? That has, yeah.
Well, I've seen evidence. I mean, I've seen a lot of literature on the like cardiac renal syndrome.
Yeah.
But levels of evidence in target species, not so sure. It's more probably
Yeah,
the
so
conceptual axes rather than dog-specific literature, if that's what you're asking.
it is, yeah. So we've drawn a lot on human literature to draw these conclusions. And as I said, the heart diseases that humans get are often myocardial rather than valvular. So they're often systolic failure, which is quite late in the process of degenerative mitral valve disease, which is what we see most commonly. So they get systolic failure early, and therefore that kind of link between cardiac and renal. So I have to say that this probably I discounted it a fair bit when I was studying, because I sort of thought that's just not really that relevant to us. But actually they've now, 2023, there was a good sized study that demonstrated that dogs with heart disease progressed from stage 1 to stage 2 CKD much faster than dogs that didn't have concurrent murmurs. I'm not talking about B2 plus heart disease. I'm talking about dogs with murmurs progress much faster. So there is definitely elements of this that we really probably need to focus on, and they're particularly the fluid retention, RAAS activation, hypertension, impacts of heart disease that are going to impact the kidneys that we can really target therapeutically. So we don't have enough evidence to say, okay, these are our recommendations now. So as soon as a dog with chronic renal disease gets a murmur, you start them on pimavanserin to support systolic function. That's not a recommendation, but I think that's where research needs to go, or I hope research goes, in terms of determining what the impact of the interplay is.
When you say RAAS, because the other thing is from a myxomatous, degenerative valve disease, when you say RAAS, I think, do you include in that the fibrotic effects in the heart that are being triggered as well?
Good question.
Because I kind of aware of this a bit more from understanding the herbs that we use. I guess in my practice, that's we sort of use herbs that cover this. But MMPs, the matrix metalloproteinase issues, that part of RAAS is also it drives more extracellular matrix in the mitral, it progresses. I think it can progress the mitral valve dysfunction by cardiac fibrosis as well. But I guess that's probably part of the conventional RAAS blockade understanding.
Absolutely, and we don't do enough histology on hearts to know how that remodeling kind of works, but we know that there's inflammation in the heart muscle in dogs with chronic mitral valve disease, and we also know that contributes to fibrosis. There were some studies, I'm going through the archives, but coenzyme Q10 decreased progression of heart disease. And kidney disease. And kidney disease.
Well, that's why I know we're interested in the mitochondrial dysfunction, because CoQ10 is like the standout mitochondrial treatment.
Yeah, right. So I've kind of got coenzyme Q10 as an antioxidant in my head.
Yeah.
But there's obviously a lot of antioxidants you can choose from, but that's the one specifically that was beneficial in progression of heart
Mhm.
disease.
Resveratrol's another polyphenolic antioxidant that has evidence in cardiac
Very interesting.
and renal, actually.
Very interesting. What do we use that for?
Resveratrol,
Yeah.
cardiac protection. It's got evidence as a cardioprotective against doxorubicin. We use it to get drunk because it's in red wine.
Maybe that's what I said.
That's where most people have heard of it. It's like the red wine. The good thing, like, that rationalizes all alcohol consumption.
Yeah,
The
and dark
tiny bit,
chocolate.
a tiny, yeah. Tiny bit of resveratrol in red wine.
Just a tiny little bit.
But then the other one that does all of those things is omega-3.
Yeah, right.
Yeah.
Because omega-3's got the most evidence for renal dysfunction.
Mhm.
And the main kind of targets there are decreasing inflammation associated with like the target organ impacts of hypertension and endothelial dysfunction, particularly where we get clots in those little glomerular capillaries that then cut off the blood supply to the nephrons. Omega-3s have, particularly with protein losing nephropathies, are really important in decreasing that inflammation. Is there any downside to omega-3s in these patients?
No. Or it depends if they're on any blood thinners, possibly there's a duplicate, like an additive effect. But if they're not on like classical like blood thinners, I would say there's benefit. I mean, they're also anti-fibrotic and anti-arrhythmic. So, but I don't think there's any like nutrient drug interactions with arrhythmic drugs.
No. So most of these patients aren't on blood thinners unless they've got a protein losing nephropathy. So that would be the one kind of like renal disease that might make me go, okay, no reason to not start omega-3s or coenzyme Q10. But there's no real contraindication. So if you do have very proactive owners who aren't overwhelmed by the like big story and the medications and stuff like that you're recommending, it's certainly not a bad thing because it does support, as Matt said, both the kidneys and the heart. How would renal disease being present impact your interpretation of the cardiac biomarkers?
I think pro-BNP or natriuretic peptide, I think reduced renal clearance could falsely elevate the levels.
Yeah, absolutely. So it does make it a little bit harder to interpret. Troponins the same. So we don't use troponin a lot, but does anyone know what troponin is?
Marker of myocardial damage. It's like the ALT of the liver.
Good. Yeah, exactly right. Yeah. So this is, I think troponin's probably more relevant to cats. We've got a little bit more evidence in cats because they get predominantly myocardial diseases and often inflammatory myocardial diseases. That interplay between renal disease and heart disease in cats, particularly with myocarditis associated with whatever underlying disease they have, it's going to be much harder to interpret. Just something to keep in mind, really, if you're doing that regularly. Any interpretation of biomarkers, typically if it's elevated, do an echo would be my recommendation, just to correlate, and obviously blood pressure and hydration status and stuff as well. Make sure you match.
Just a quick question, which is maybe for another day, or offline, take it offline. Are you doing cardiac biomarkers regularly, or are people doing them regularly, troponin and pro-BNP these days?
In cats, yes.
In
Yeah.
cats, yeah. And like DCM dogs, like Dobies, and I think that was the last time I did one was in a DCM. But there's like, from memory, if they're less than 20 kilograms I learned pro BNP was good, like if to differentiate cough, and then if they're greater than 20 kilograms, use troponin. That's just what I had a memory of learning a long time ago, but maybe outdated because cats.
No, well, I think the biomarker research is like only just kind of getting to a point that we can interpret it clinically.
Mhm.
We don't see enough Dobies, we don't see enough DCM dogs to really establish patterns, I don't think. They've got
Yeah.
like breeding colonies where they've done all of the research on for those dogs, and there's definitely a potential application, but I'd have to look up what
Okay.
the cutoffs were and stuff. Cats, we use ProBNP all the time because an echo in cats is often not benign. Like you've often got to give them sedation. They need to be restrained. They've got to be in a vet clinic situation, which is very traumatic for cats. So particularly if they get annual blood tests done anyway, I would say just do a ProBNP. Mariko is a cardiologist that we've worked with for a long time, and her recommendation is if the ProBNP is above 100, the cutoff for normal is 150. So even she's sort of saying even if that ProBNP is at the upper end of normal, it's probably worth doing an echo if there's predisposing factors. Where I would do a troponin is if I'm concerned that this cat's heart disease is an acute inflammatory heart disease as opposed to chronic myocardial disease. So cats get these kind of two forms of heart disease where one of them will progress, like it's a sort of progressive myocardial change, and the other kind of they've got quite bad heart disease and then it just gets better. Or stays very stable after that point, never progresses. And we know that cats get a lot of infections which would cause myocarditis, so the protozoal infections and the weird bacterial ones like Bartonella and stuff like that, as opposed to dogs who get less of those myocardial infections. So every now and again I do oh man, I had a cat with FIP granulomas in its heart a couple of weeks ago. That was bizarre.
Oh.
So every now and again, when I see something like that, I'll say, let's do a troponin level to quantify this, so we can then sort of say, okay, it was normalized. Let's do another echo now and say, okay, that's this cat's baseline. But it helps us to target therapy rather than with the more chronic heart diseases like degenerative mitral valve disease. I probably wouldn't use it. It's very cats biomarkers.
Okay. Thanks.
All right. I'm not sure whether it actually helps, but
No, really helpful. Yeah.
So for these patients where we're either starting them off furosemide or they're older and we're assuming they've got some renal dysfunction or they've got like stage 2 renal disease, what do we want to be kind of monitoring as a baseline fairly regularly? What's our list?
Resting respiratory rate, so you can tailor your diuretic dose as low as possible.
Perfect. Yeah.
To help your kidneys.
Mm-hmm.
It's probably the least invasive thing you can do.
Yeah, good. And something that's so important to get the owners engaged in understanding the balance, the kind of tightrope we're walking.
Probably 3 monthly lights, renal parameters, phosphorus, PCV, thyroid. If it was an exam, I guess, as you told me, just throw in more things, right?
Yeah. I
CRP.
lights, PCV, thyroid. What else did you say?
I would just say about like a total annual profile plus CRP. I mean, yeah, but yeah, the markers of concern for me would be the 3 renal parameters: phosphorus, potassium, sodium, maybe calcium, PCV,
PCV. Yeah,
hemoglobin,
good.
thyroid.
Thyroid. Yeah. What else? So that's
A blood pressure.
Yeah.
Yes.
Urine.
Yeah. What are we checking for in urine?
Proteinuria, USG.
Great.
Obviously blood glucose along for the journey.
Yeah, good. What else? It's a tricky one.
Body weight.
Yes, good.
Mhm.
Really important. Both cardiac disease and renal disease are associated with cachexia. I'm pretty sure that's how you say that word. Just it
Yeah.
doesn't read that way to me, but I'm pretty sure that's right. Is that right?
Yeah. Okay. That's how I've always said it, but
There's two ways
Sure.
of saying it, I think.
There. Okay. It's funny working in our team with very highly educated people. We all pronounce things differently. It's because we learn from books. Excellent. So what are we going to do in these patients if we see a proteinuria?
Telmisartan,
Good.
ARBs.
Yeah. So this is where like proteinuria has its like really nice guidelines on management. But when we're crossing over heart disease and kidney disease, those guidelines, you sort of got to say, oh, is that the right thing for the heart as well? So in these dogs in particular, I'd probably consider an ACE inhibitor in these guys just for the theoretical benefits.
Gotcha. Yeah, with the heart.
Yeah, telmisartan's got better benefits for hypertension. So if it was proteinuria associated with hypertension, I might go telmisartan. But if it's proteinuria in isolation with no hypertension, then I'd probably go ACE inhibitor.
And just check if it works to get the protein under control, right? Because the ACE inhibitors are not as good for proteinuria because there's like secondary mechanisms that. Or is that when you're saying like when it's more hypertension associated proteinuria, that's where the telmisartan would be better.
Exactly. Yeah. So telmisartan is better with blood pressure. So it will have more impact on blood pressure than the ACE inhibitors will. So I want to hit the hypertension and I want to hit the proteinuria. So telmisartan would be my first choice there. ACE inhibitors, if it's proteinuria not associated with hypertension, ACE inhibitors and telmisartan, the studies that I've seen, and there might be more recent ones, but is that telmisartan is non-inferior to ACE inhibitors for managing proteinuria. So it was as telmisartan was kind of being released, they did a big study to show that it was as good as ACE inhibitors. It's also
but with telmisartan, like I mean, it's a good point. I think I respect, like I think the use of ACE inhibitors for the heart is good, but is telmisartan not also good for the heart, and we just don't use it for that because it's essentially a RAAS blockade as well, and it would have similar effects as benazepril on the heart, no?
So what I like about an ACE inhibitor over telmisartan is ACE inhibitors block production of angiotensin, which is actually one of the things that
versus the receptor blockade.
Yes, as opposed to like we've still got the same amount of angiotensin, if not more, because we haven't stopped that cycle with a receptor blockade. So we've got continual.
There's like a reuptake kind of concept.
So we're trying to minimize fibrosis and remodeling. Blocking the production is going to be better than blocking the receptor.
Okay.
As a result of, in theory, but we don't have, like telmisartan just hasn't been around long enough for us to document impact on cardiac remodeling because that's a very chronic process. Be very interested to see, but that's my theory. Okay. That's kind of all I wanted to cover. Does anybody have any questions or specific cases or anything they want to have a look at?
Oh, sorry, you go, Rebecca.
Oh, thank you. No, just with the ARBs and the ACE inhibitors, I kind of heard the other way around that with ACE inhibitors, you still get some RAAS escape because angiotensin can be produced by non-RAAS factors as well. So it may not be as effective as a blockade, which actually blocks the effects of angiotensin at the macular denser of the kidney or something.
Yes.
Maybe that's a cat thing. I don't know.
That's what I was. That was where I was going with the superiority for proteinuria because I think there's like a chiasm pathway that it was not an incomplete blockade.
So this is why I think telmisartan would be my first choice for hypertension causing the proteinuria, because where that receptor is in the kidney is going to, I guess, decrease the impact of hypertension on the glomerulus, as opposed to ACE inhibition, which isn't going to drop the blood pressure enough to protect that glomerulus, and we're going to get ongoing damage. So I think angiotensin receptor blockers are better at blocking the target organ damage from hypertension. ACE inhibition is better at blocking activation of that system, if that makes sense. So if you've still got angiotensin not having an effect on the blood vessels, not having an effect on the heart because we've blocked the receptors, we've still got upregulation of aldosterone, don't we? Which means we've still got sodium and fluid retention and increased preload, but we've just got now the vascular, like the arterial system being able to accommodate that better. But the venous system's still getting like congested. So we haven't really addressed that side of it, whereas the ACE inhibition, in theory, works better. I think there's pathways that we don't understand that will mean that telmisartan has much more benefit than just that. But because we know it's more effective in a lot of ways, or at least as effective in a lot of ways. So yeah, I think there's more to be learnt about telmisartan, would be my response.
I have a question for telmisartan. I don't have that many patients on it, but a lot of them got anemia, which in the literature was documented as a rare side effect, but I've seen it in concurrent patients at the same time that they've got anemia, that initially the internists were like, nah, it's definitely not telmisartan, but then we dose reduced like a couple of times on a couple of dogs, and the anemia was corrected with dose reduction on telmisartan. So I was wondering if you see that with bigger numbers, or I just had like an unlucky couple at the same time. I was just curious that it was determined to be like a rare side effect, and I saw it with and I have a high index of suspicion that it was actually the actual cause in a couple of patients, because we dose adjusted and it improved.
I don't know, but I predominantly prescribe telmisartan and then don't get any follow-up.
Right. And I guess people may miss it because they're like, oh yeah, it's kidney disease. So like, yeah, anemia could be that it might just be like underdiagnosed because it's assumed that it's an EPO issue.
Yeah, completely.
Matt, were they dogs or cats or both?
Dogs.
Interesting.
Yeah.
I'll keep an ear out for that.
I don't think I've ever seen it in cats,
Yeah.
but I treat way more dogs than cats nowadays. It's never been like the internist that I work, an internist down in Melbourne that I was working with did eventually be like, yeah, it looks like the telmisartan, and kind of recognized it, because initially she was like, too rare a side effect, like won't be that, and which is fair enough. But then it was deemed like the anemia was not, it was just like creeping down in like the like low 30s, and will like if it stays maybe low 30, I can't really remember, but they're like, oh, if it gets below 25 or 27 or something, it was a bit concerned. It was just kind of dipping below the reference interval. It wasn't like a PCV of 20.
Yeah. Interesting, because as we know, that an impact of anemia in these patients is actually quite high. I'll keep an eye out for that now, but as I said, I often prescribe and then don't get any follow-up on those patients.
And then the other one is with ACE inhibitors and telmisartan. What's the risk of there's some risk of it, and I think we touched on this about the glomerular, like going the like nephron loss, because you're dropping things too quickly, and it's like on a knife blade, and it was just too much. But there's also I also like there's risk of both acute renal injury, on acute on chronic, from using both, that is like there's a risk of acute renal injury on using both of them, correct? And is it just that mechanism, or is there a more predictable if that's true? Is that true that there's some risk that, because I remember I had a dog that had an acute on chronic injury episode and was at SASH, and they pulled the telmisartan, I think from memory, because they're like, it's no longer safe right now. All those.
So what I would say is that any medication that drops blood pressure and impacts renal perfusion in the face of other causes of hypoperfusion, or like if they've got gastro, for example, they've got fluid losses in their gastrointestinal tract, their blood volume's gone down, their blood pressure's gone down with it, and then you amplify that effect with a medication that's been very appropriate long term, but then all of a sudden you get no renal perfusion. So that's something that I'd say dogs in heart failure, dogs with kidney disease, like dogs on furosemide, I should say, and dogs with kidney disease have no capacity to retain fluid. So if their losses increase from another avenue, then they're really susceptible to hypoperfusion injury and acute kidney injury. So we see particularly dogs on furosemide, like they get gastro and they're like, the owner's like, oh, it's just had diarrhea for 24 hours and their creatinine's 450 and it's been within normal limits. But they don't have the capacity, the absolutely zero capacity to retain fluid. So get dehydrated.
So when we had prescribing furosemide, like on our, like with like an NSAID where it's like stop and phone for advice if vomiting, diarrhea occurs, like should we be saying like stop and phone for advice if diarrhea, like or I guess on a case by case, if it's a patient with a GI history, I mean, it might be something that because I like to educate my patients about dynamic furosemide dosing to SLRs, or RAAS, but that might be another factor. 'Cause I definitely have seen that before.
So when I prescribe ACE inhibitors, if I have to prescribe ACE inhibitors, I say any gastrointestinal signs, stop immediately.
Okay.
Yeah. And if they come into hospital needing like intensive for diuresis because they've gone into congestive failure, I stop the ACE inhibitor at the same time. So anything that's going to decrease renal perfusion, whether it's iatrogenic or illness, I will stop ACE inhibitors. Furosemide, I don't want to stop. It makes me so nervous. So sometimes we'll drop the dose, sometimes we skip a dose, but that's a process that I want to be talking to the owner twice a day if they're outpatient, or I want to be watching them if they're an inpatient. Yeah. And a lot of these patients I'll hit with some subcut fluids because I don't want to put fluid into their vascular space because that immediately changes the load on the heart. But with subcut fluids, it's going to be absorbed dependent on their hydration status because it's like down its gradient, essentially. So I feel like that's a safer option. Right. Thanks, guys. We'll wrap up. And the next one is going to be cardiac physiology and pathophysiology of congestive heart failure. Correct? Yeah, super. And Helen's going to run the next one. And I'm going to come and heckle.
Thanks, Anna. That was really helpful.
Thanks, guys.
Thank you so much. Bye, Brian.
Yeah, good. Thank you, Anna.
No worries.
Thanks.
Bye, guys.